In treating dental students, I found that what was in the didactic lectures did not translate well into the clinic. So therefore, I developed what I referred to as a treatment-focused diagnosis, or a TFD. The first thing we need to look at is what should be included in a periodontal examination and treatment plan. First, we need to know the clinical signs of periodontal disease, the predisposing or etiologic factors, what is a diagnosis, what is a prognosis, and what are the treatment options. Here is a worksheet that I think should be provided to students where they can actually mark the things on there. It's not the purpose of this particular video to discuss the signs and symptoms of periodontal disease, nor to discuss the predisposing factors. We're going to focus today on section 3 and 4. One, a quantitative way of determining bleeding on probing, but the major focus is going to be on number 4, the treatment-focused diagnosis. At the end, we will discuss briefly 5 and 6. When students brought their patients into the periodontal clinic, they were asked, what is the periodontal diagnosis? And we randomly selected 100 patients and 100 students. And to answer that question, 45% said bone loss, 10% said calculus, 30% said plaque, and only 15% said gingivitis or periodontitis, but it was unclear in their mind the difference in treating gingivitis and periodontitis. So that was the impetus for doing this study, and points out that what students are taught in the didactic lab does not always necessarily transfer over to the clinic. Now here's an interesting finding. When students were asked to recommend a treatment plan, made no difference whether the patient had a gingivitis, a healthy mouth, or a diseased mouth. 100% of the students, when we asked what is the treatment plan, they said scaling and root planing. They did not seem to understand the difference between scaling and root planing when scaling is done and when root planing is done. And regardless of whether it was periodontal health or not, because they were in the periodontal clinic, they felt obligated to say that all patients had bleeding on probing. So we see the understanding or the misunderstanding that students have. So determining a treatment-focused diagnosis, number 4, we have health. And health is basically no bleeding on probing, no suppuration, and no pockets. This patient simply needs the treatment of what's often referred to as a prophy, removal of supragingival plaque and calculus, and reinforced home care if necessary. Much discussion went on with various faculty members in dealing with health with attachment loss. This is a patient that has generalized recession interdentally as well as facially, and generally this is a result of periodontal surgery. There's no bleeding on probing, there's no suppuration, and there are no pockets. So what we're dealing with as treatment on this is the same as a healthy mouth, and basically even though there's attachment loss, we're going to just do a prophy on this particular patient. The dilemma: what if we have superficial redness, bleeding in areas of recession, but have no probing depth? What is the diagnosis? Basically, this looks like a gingivitis, but when we have attachment loss, the true diagnosis on that is a periodontitis. Gingivitis. We're all familiar that there should be some bleeding on probing. Pockets are present from swollen tissue, but not from attachment loss, and the treatment is scaling and polishing if slight to moderate. If you have a severe gingivitis, perhaps you may want to do a gross debridement, reinforce home care, and follow that up with scaling and polishing. But this is not treated by scaling and root planing, only by scaling. And oral hygiene instruction certainly is necessary, as well as a follow-up reevaluation. Now let's look at several different cases of how we will apply the concept of the treatment-focused diagnosis. The first patient that we're going to look at, patient number 1, has a slight generalized gingivitis. The treatment is very basic on that. Scaling of the entire mouth. Now, because this is a gingivitis and there is no attachment loss, obviously using the term root planing would be inappropriate. Second, we want to polish to remove any extrinsic stain, and then we want to give oral hygiene instruction. And certainly you don't want to give oral hygiene instruction before you do the scaling and all, because the calculus interdentally may interfere with, say, flossing. So we want to give oral hygiene instruction after we have completed our scaling and our polishing. And because we're dealing with disease, gingivitis is a disease, we need to reevaluate to see how effective our home care instructions have been and do any other instrumentation that we find necessary. And here we have the worksheet, which I think should be available, and we'll talk about that more in detail. This is section 4. And the student should go in there and circle what applies. A gingivitis, generalized, and slight. Patient number 2. And here is the worksheet on patient number 2. The patient has gingivitis. It is localized in the lower anterior area. Now, what does this tell us? What is the treatment going to be on this particular patient? You're not going to necessarily do instrumentation in the entire mouth because it's healthy, but just in the lower anterior would be the only place that you would do the scaling. And then you would certainly do your polishing, and even though it's slight in the lower anterior, perhaps you may want to wait until the next recall appointment to do the reevaluation. Patient number 3. This is a periodontitis. It is localized. It is slight. And it is in the molar areas on the upper only. Now, what does that tell us? First of all, the rest of the mouth is healthy. So all we're going to do is focus our treatment on those maxillary molars. And they're going to be treated by scaling and root planing, because with a periodontitis you have attachment loss. And certainly you're going to want to follow up and reevaluate on this as well. Patient number 4. Patient number 4 has a periodontitis. It's generalized and it's slight. What are we going to do? We're going to go in there and we're going to do root planing throughout the entire mouth, because this is a generalized problem. Because it's slight, if we do a good job of root planing and the patient practices decent home care, we know that this case is not going to require surgery. So now we begin to see the impact that a treatment-focused diagnosis can have on communicating with the patient, as well as helping the student understand exactly what they're treating, why they're treating it, how they treat it, and why they're treating it. Patient number 5. Patient number 5 has a generalized moderate periodontitis. So let's not spend a lot of time on this, because what we know here, we're going to go in there and we're going to root plane the entire mouth, do what we do on a regular periodontitis. But with a moderate case, then you're going to probably want to reevaluate that sooner rather than later. If it is slight throughout the mouth, you may delay reevaluation to a recall appointment. However, if it's moderate, I would suggest that you have the patient in and reevaluate, because some isolated localized surgery may be indicated. Patient number 6. Patient number 6 has a generalized severe periodontitis. Root plane the entire mouth. Certainly you're going to need to reevaluate, and in all probability this patient is going to require some periodontal surgery. Patient number 7. This gets into a little more complicated situation. Remember, in the other cases where we had a localized periodontitis, the rest of the mouth was healthy. But on this patient, you've got a generalized gingivitis, and in the areas it's localized and it's slight in the molar areas. So you are going to do scaling throughout the mouth, but in those maxillary molar areas, you're going to do root planing, and because it's slight, as we've talked about earlier, in all probability, no surgery is going to be necessary. What about bleeding on probing? We want to quantitate bleeding on probing. Slight bleeding on probing is a trace, it's delayed, it means there's minimal inflammation, and therefore not very significant. A typical on this would be on the mandibular left, you probe tooth number 18, you see no bleeding on probing. You probe tooth number 19, you see no bleeding on probing. But when you get to tooth number 20, maybe on 18 or 19, a little blood has oozed out. Really not significant, but we do need to be aware that there was some bleeding on probing. Moderate bleeding on probing is spontaneous, and it means there's a greater inflammatory response and a more significant clinical finding. In this case, let's say that you place the probe in a pocket and it measures 5 millimeters, and you withdraw the probe, and as the probe is withdrawn, blood follows that out. Severe bleeding on probing is profuse and persistent and means there's a greater level of inflammatory response. In this case, typically the tissue is somewhat swollen, reddened, and as you begin to probe, before you even reach the depth of the pocket, blood oozes out. So this is a good way for students to learn a quantitative way of doing bleeding on probing. Now let's summarize what I hope you've learned. We've got 6 factors on this flow sheet. The first 2 factors, the clinical signs of disease, and the etiologic factors we did not discuss. Our focus was on number 3 and number 4, quantitating bleeding on probing in the treatment-focused diagnosis. On the bottom, 5 and 6, we must touch on slightly. The treatment options are quite obvious. Let's focus on number 6, treatment for bad breath. This is something all patients are interested in, and very little is addressed in this area in most dental clinics. So to be effective on treating bad breath, halitosis, malodor, or whatever you prefer, please go to the web textbook and look at the least expensive, most effective mouthwash, one video, as well as the video on the importance of cleaning your tongue, because most bacteria associated with bad breath are on the posterior third of the tongue. Let's review what I hope that you have learned. First of all, what students learn in the didactic portion of their dental education does not necessarily transfer to the periodontal clinic. Second, because patients are in the periodontal clinic, students feel obligated to say that there is bleeding on probing and that the patient is going to have a standard term scaling and root planing. This little video, I think, points out to students how to remedy those 2 particular problems. As stated earlier, 100 patients were selected randomly to gather this data. And after using this in our periodontal clinic at the University of South Carolina, after a few sessions, students seemed to grasp what we were trying to do. And in reality, it took very little time, and certainly they got a much better understanding of what disease they were treating, how it should be treated, where it should be treated, and certainly the outcome of treatment.